Hi, good morning, everyone. It's a real pleasure to welcome Dr. Khurram Nasir back to Yale. I think most of you know Khurram. A little bit about his background. He did his MD degree in Pakistan, followed by an MPH at Hopkins, after which he did his internal medicine training at BU and then came to Yale for cardiology. I believe there was a brief stint in radiology in between there, but I don't have the details, which also informs a lot of his work around the really landmark work regarding calcium scoring and how to use calcium scoring and the power of zero, which is a term that he coined, used in multiple different clinical as well as population health methods. His career has really soared wherever Khurram goes. He really starts and then grows incredible programs that are designed to address cardiovascular risk factors and health in large populations. He first did this at Baptist Hospital in Miami. He was back here at Yale for a brief stint and is now the division chief of prevention and wellness in the Department of Cardiology at Houston Methodist. And he also continues to be an adjunct professor here at Yale. I can say on a personal note that Khurram and I met on my first day of fellowship when he really showed me the ropes of how to be a fellow clinically on the floors. And I think he's done that for an incredible number of mentors. To see his incredible amount of mentees, to see his mentee team is really unbelievable. I challenge you to go to any meeting where Khurram is presenting, and you will find his mentees really exploring and diving deep on different topics as they relate to cardiovascular disease. His topic today of financial toxicity is certainly one that he has really brought to the forefront in helping us to understand the struggles of our patients, how financial toxicity, how poverty, how lack of wealth impact our patients' cardiovascular health. So it's a pleasure, an honor to welcome Khurram back, and I'm excited to hear your talk today. I also just Oyeri mentioned, I also did want to give a plug for a prevention symposium that will take place this weekend. We'll put the information in the chat, but it's a real all-star lineup of different people giving talks on really great, provocative, important topics in the field of preventive cardiology. So welcome, Khurram, and I'll hand it back to you.
Wow, Erica, it's such a beautiful introduction. You know, honestly, as you were speaking, everything was rushing through my eyes and all the good time we had together, and especially the first night of call when you did your first call. It's just been an amazing journey and a wonderful family. I truly wish that we were there together in the auditorium and spend more time in person, hopefully soon. But at the same time, I really want to thank you, Erica, Oyeri, Rohan, and Eric, in spite of being, I don't consider myself an expert, really an apprentice in this space, for giving me the platform to share the thoughts that I think have continued to evolve over the last few years, really cemented during my stay at Yale, working with Harlan. But more importantly, today, rather than trying to give back, I think I'm here to benefit from your individual feedback and positively shape our trajectory on this key issue. So, financial toxicity. Now, many of us may be familiar with this term vaguely, highlighted in media circles over the last few years. So, if you look out, there is no formal definition, but you can refer it to a broad set of detrimental effects of excessive financial strain caused by medical care on the well-being of the patients. Not only that, but their families and societies. Think of it as a side effect of a medication or a procedure that may unfortunately produce unintended harm and deleterious effect. Now, this term has gained immense popularity in recent past, especially within the oncology community, with continued escalations of medical care for cancer treatment, and even is part of, I would say, the discussion, integral part of any discussion that happens in the cancer world. However, I'm sure many of you might not be aware of this issue as far as cardiovascular disease is concerned. And honestly, a few years back, neither was I. So as Erica pointed out, and I'm sure many of you would be wondering that how a preventive cardiologist who spend most of his time passionately advocating, even with all of you, the role of imaging and the power of zero and building clinical programs. And now, of course, inspired by Harlan, engaged in building digital solutions for healthcare, is talking about financial toxicity. I can tell you this was not planned at all. And I was truly ignorant of this issue until I think it was 2016 when I was in Miami. A very dear friend of mine, a small business owner in his mid-40s, suffered an acute heart attack with VT arrest. And of course, thanks to the recent advancements in resuscitation access, procedures, appropriate pharmacotherapies were saved, completely recovered, returned home in good health to the joy of his family and friends. But honestly, the good news was short-lasted. He was uninsured. He was hit with more than a $120K bill. It took us literally months to help him through these challenges and eventually helped him negotiate at least around a half of the bill that was charged. And now, I can tell you, though his health is better today, he's still saddled with debt, and the side effects of what I've seen upfront are significant. Now, my friend is not alone and is not an isolated case of those bearing the pearls of being uninsured. Just in my own backyard in Texas, of course, this was an interesting case. A school teacher, a swimming coach, Drew Calver, had a heart attack. His neighbor took him to the closest emergency, and unfortunately, he was out of network. So he was subject to what we refer to as the surprise billing, in which the normal insurance protection doesn't even apply, and he got a bill of more than 100K. Now, one need to ask, how does this medical bills get so high in the first place? We all know these are all arbitrary, can be anything. If you look at the bill that was published and the prices for every line item, $200 for a blood test, $20,000 for one single stent. There is a markup for everything, and what we have is really a common situation in American medicine in which the hospital and insurance, when they disagree on a price, the patient gets left out holding the bag for the difference. Another anecdote is Leon Lederman. He won the Nobel Prize in 1988 for his pioneering physics research, but unfortunately in 2015 sold his Nobel Prize for close to $750,000 to pay for his mounting medical bills. He had started suffering memory loss, died in an Idaho nursing home. Now, I think in a lot of ways, Lederman's story represents the best and the worst of US. He was born in 1920 to a father who worked in a laundry facility. He then went on to discover the Higgs-boson subatomic particle, the so-called God particle. But even an accomplished physicist and university professor isn't immune from what we call the sky high healthcare prices in US. And myriad anecdotes from personal experience to my friend, a Nobel laureate who sold his medal to pay medical bills, or even Hedda Martin, who was rejected as a transplant candidate and suggested to raise more than 10,000 via funding, online funding, which is pretty much common part if you want to have a transplant. And each year, more than 250,000 GoFundMe medical campaigns. And even last year, it was raised about $1 billion. And Harlan and some other researchers just pointed out recently that over the last 10 years, more than $9 billion been raised. All of this attests to the financial toll of illness on American families. Now, you would think this is about acute care, but not really. I want to just give an example. A 72-year I saw a patient in 2017, a 72-year-old retired professor of epidemiology. He had a Medicare Advantage plan, earns about 80K, and to whom I prescribe PCSK9, one of the few interventions that have shown, if not a very large, but meaningful improvement in cardiovascular outcomes. As a member of my cardiovascular community, I enthusiastically welcome the FDA approval of PCSK9 inhibitors, but honestly, these celebrations were short-lived because literally 3 months after he came back and was unable to afford an ounce of prevention. Now, like my patient who had to pay nearly $300 per month, as you can see here, 60% of other patients prescribed the same medication abandoned them. Clearly a very unfortunate situation. So now coming back again, as a preventive cardiologist, while I'm extremely proud that over the last course of maybe 20 years or more, we have seen major advancements in heart disease diagnostic treatments that has led to significant improvements in clinical outcome, and quite possible that in the next decade, we may be finally able to lose the tag of the #1 killer in this country, something we all need to celebrate. But these gains have come with a price. It's an undeniable fact that cardiovascular disease now and has been the most expensive disease in the US, with an estimated healthcare cost of $500 billion last year, expected to rise up to 800 billion in 2013. And some estimate that it's responsible for almost 1 in every 6 healthcare dollar that is spent. So now, just also to give you an example, that the economic... Sorry? Yeah. Okay, so just to give you an example, apart from the national, just the direct cost for care of managing these patients is not meager. As you can see, conservative average cost of managing a patient with uncomplicated cardiovascular disease is around 8 to 14K per year. And that really depends upon the burden of the disease. So now, as you've seen that the overall cost is really mounting and going up, and significant financial, societal, individual level overall cost burden, and this temporal changes that of increasing healthcare expenses are really rising over time. We are also seeing a new phenomenon in many years, something I wasn't aware, and I'm sure not many of us in healthcare, the business of taking care of patients, are well aware, where we are seeing that insurance plans are now requiring more cost sharing. There is a significant proportion of treatment costs that is directly shifted to the patient in various forms, such as high premiums, deductibles, co-pays, co-insurance. And of course, as you start diving deep into these financial aspects, it raises concerns of the impact of the financial toxicity of this group in the patients. So as a result, when we started digging deep into it, it came as no surprise that almost any national survey have consistently reported medical bills being on the top list of concern for US citizens. For example, this survey done by University of Chicago, more people are afraid of paying their medical bills, about 40%, than actually becoming seriously ill, which was around 30%. Now, if you look at the Kaiser Family Foundation, found that 67% of people worry about unexpected medical bills. And among the top 8, apart from that, insurance deductible, prescription drug cost, insurance premiums rate higher than basic staples of life that I should be thinking about: rent, food, gas, college, retirement. It's really heartbreaking that this problem, while this problem I have seen upfront closely in where I grew up in developing countries, where the health system is not yet mature. And however, within the developed world, this issue remains uniquely an American problem. People in Canada, Australia, UK, many other countries who have the same misfortune of getting sick don't face the same risk of massive bills in the aftermath. And this is according to Commonwealth Fund. So now, putting all of these 2 years of experience and now affected at a personal level, sobered with stories from families, patient asking to cut back on medications, friends taking loans, and seeing all these anecdote cases reflecting whether we, who pride ourselves as the solution in healthcare, are contributing or even becoming part of this problem. And how does it relate, especially to cardiovascular disease, seeking how are we doing or we score on some of the matrices. For example, for patients with heart disease and stroke, how much are we spending on out-of-pocket cost? How much of a family income spend is on healthcare expenditures? Are families able to pay medical bills? Who are most vulnerable? If you have an insurance, are you protected? What about the quality of life, unintended consequences, outcomes, et cetera, et cetera? And when we started looking at it, I was truly astounded that while there is substantial literature and work on similar challenges in the oncology world, we found that the cupboard to be empty for cardiovascular disease. So where do we start? We were truly embarking on this uncharted journey, not knowing where to head. Naturally, the first step was to accept that maybe this is a problem and quantify and measure it. Because without measuring, we can't truly understand the magnitude of the burden. And until a few years back, people didn't even accept that financial toxicity is a real clinical issue, especially for cardiovascular disease patients, and maybe just a social political slogan. Now, I consider myself extremely fortunate to find an unremarkable ally in Rohan, and more than under Harlan's guidance to lead the first work in this space of its kind, in which we sought the national data sets of adults with cardiovascular disease in the Medical Expenditure Panel Survey, which is a nationally represented serial cross-sectional study of US families. Goes detailed serial interviews not only on the health status, but it's unique in the sense it captures financial characteristics, healthcare access, financial support of their healthcare needs, and of course, most popular data set that has been used among health economists. Now, in this study, what we found, to be summary, individuals age 40 and above, where we sought out the goals to detail the out-of-pocket costs, among nearly 23 million patients. What we found that the overall mean income is very close to what we know, about 57K. However, unfortunately, 40% of the CVD patients belong to the low income group. And the very basic question that we wanted to ask is, how much are we spending out of pocket in accordance to some of the maybe established definitions of financial hardship, where you're spending 20% of more of your entire family income on healthcare, or even catastrophic healthcare expenditure if it's more than 40% defined by WHO. The results were astounding and not what we were expecting. Overall, 1 in 7 families who have atherosclerotic cardiovascular disease spend 20% of their combined annual income on healthcare cost. Not a small proportion, 5%, 1 in 20 are spending their 40% of the entire family income on healthcare expenditure. Unfortunately, the other thing that was worse than these findings, that not everyone was affected equally. Extremely disheartening that those considered the most vulnerable, where the insurances, and be it national or private, who should be protecting the low income groups, about 4 to 10-fold higher risk of spending, and even in the contemporary era. 1 in 10 families spending 40%, and 1 in 4 families spending 20% of your entire income if you have one family member with CVD. Now, if you look at the distribution of where this out-of-pocket cost is heading, in this summary figure, you can see overall, the average mean individual level, of course, it's going to vary depending upon your needs and conditions. Annual out-of-pocket healthcare expenditures amongst patients with atherosclerotic cardiovascular disease was around 2,200, 1/3 in just spent on premiums. Medications contributed to 1/3 of all the out-of-pocket, but if you take out the premiums, half of all the non-premium medical expenditures. Now, this becomes a critically important issue in the context that these insights are before the era of adoption or even approval of the novel, potentially life-saving, yet very expensive medications like PCSK9, now inclisiran's on the board, and Entresto, SGLT2s, and the GLP-1s, and it keeps on growing. Now, this is not issue just limited to patients with CVD. Similarly, high burden was also recently confirmed this year by in heart failure patients in this recent paper led by the Yale Star resident Stephen Wong under Rohan's leadership, where again we saw 25% low-income families who have family members with heart failure have high financial burden. 10% are paying more than 40% of their entire family income for medical bills. So this is kind of where a very objective measurements of how much are you actually paying out of pocket. But this is truly scratching, I would say, the top of the surface out here, because while objective financial measures, more stemming from the out-of-pocket spending on medical care, give insights on the direct financial burden to the family, I think so it's truly an underestimation. It doesn't account non-medical costs associated with seeking treatment or related to the complications that may happen, such as loss of income, transportation, work away from work, inability to really focus on other areas that may be important, and becomes challenging for especially more vulnerable, low-income groups from the accumulation of out-of-pocket spending from the time of diagnosis, eroding into the household wealth and non-medical budget. And as a result, this measurement may underestimate overall. So as a result, we then further pivoted to seek a more subjective measurements, and specifically, how burdened are these individuals? And for these insights, we sought out the cross-sectional National Health Interview Survey and specifically seized onto these three questions that provided us on the clue, led by Javier Valero, who's truly developed a unique niche in this domain. So you can see that we were trying, and what we found that the results were even more sobering than what Rohan had earlier found. 1 in 2 individuals reported difficulty paying bills, and they were paid over time with credit card, through personal loans, or bills paying arrangement with hospital or other providers. A unique happening under the bonnet that we are not very, I would say, aware of. And not only that, about 1 in 5 individuals were unable to pay medical bills at all. More prominent among those are those suffering from premature cardiovascular disease, ethnic subgroups, especially the non-Hispanic Blacks, lower income, uninsured. However, one thing really stuck us. While unfortunate, but understandable that uninsured patients have the highest burden of financial hardships related to medical bills, what was surprising that most patients, about 76%, who reported unable to pay their medical bills, were actually insured. It further underscores the fact that although insurance coverage is critical to protect against risk of financial burden from medical bills, the current structure completely falls short in protecting from financial hardship, and in fact is a major brewing issue in the current era. And maybe being underinsured is much more of a bigger problem than being insured. And this definitely needs much more detailed insights and work. So now that we had firmly established that high financial hardship is directly related to unbearable medical cares among families, be it objective financial hardship leading to catastrophic healthcare expenditure, or subjective leading to difficulty paying bills, inability to. The next line of investigation is try to truly understand its unintended consequences. How do people cope? What's their overall distress, and what does it lead to? Now, our first area of attention was medication non-adherence, of course, led by Rohan. It's well established that the care of patients, at least in our world of atherosclerotic cardiovascular disease, heavily relies on medications to lower the risk of adverse outcomes. But at the same time, we are well aware that as many as half of Americans who are prescribed such medications may not be able to take them routinely, at a cost to eventually to their health and subsequent cost to the health system. But I was surprised that many of us were not openly talking or even quantifying whether cost represents a specific venue for these unfortunate challenges. Now, what Rohan found was not pretty and was disheartening. In fact, 1 in 8 individuals, again, we are talking about the pre-era of PCSK9s, SGLT2, and Trestos, GLP-1s, reported cost-related non-adherence, and they were not taking their prescription just because of the cost. Now, cost-related non-adherence can come in many forms. Overall, as you can see in this graph, about 10 to 15% individuals with CVD have either stopped taking medications, they've delayed filling a prescription, or took a less to save money, which we has clearly reduced till 2016. And we started seeing an uptrend and unclear that is this related to a lack of expansion of insurance coverage that we started seeing happening in 2016, or a more expensive medications coming to the markets, something that we need to further investigate. Now, when you look at these patients, about 1 in 4 reported asking their doctor to lower their cost medication, something that we don't pay much attention. But if you ask the patients, I'm seeing that much more common than this. However, if you had cost-related non-adherence and you were skipping and delaying and cutting back on medications, almost 3/4 of these versus just less than 20% would ask doctors to lower the cost. Nearly 17% would use alternative therapies if you had cost-related non-adherence, whereas less than 2% if you don't have them. Now, while this cost-related non-adherence may also be considered as part and the parcel of the financial toxicity, we also wanted to postulate that would there be additional unintended consequences with higher out-of-pocket cost associated with cardiovascular disease management. So, for example, food insecurity. It's a state that's defined as lack of consistent access to nutritionally adequate food due to socioeconomic circumstances. Usually it's measured by a validated 10-item US adult food security survey. Now, just recently, Shivani Mahajan, a superstar Yale IM intern, recently showed that food insecurity is definitely under-recognized among patients with CVD. Most related to the patient's socioeconomic status, where access is limited to adequate food, has very strong association and relationship with other social determinants of health, more commonly seen in ethnic, vulnerable minorities, immigrants, those with low socioeconomic. In general, if you are going to go back and see patients today with cardiovascular disease, nearly 1 in 7 of them and their families would be food insecure. Pretty sobering insights. Now, it's true that overall, within patients suffering from cardiovascular disease, food insecurity is not uncommon, but the condition is extremely prevalent among the group that has reported, for example, who have reported inability or difficulty to pay medical bills. For example, higher the proportion of financial hardship, as you can see in this slide, from medical bills, greater proportion of family report that they cannot afford a balanced meal. They're worried about getting the next meal, cutting back on food, skipping meals. 20% even face hunger who are unable to pay medical bills. All of this happening right under our nose in the richest nation in human history. Next, what about significant financial distress as a construct of overall anxiety and discomfort experienced by these patients with CVD diagnosis and its treatment, resulting from the cost of healthcare, low income, or even lack of health insurance. Clearly, again, as you can see here, those facing higher out-of-pocket cost, higher financial burden, inability to pay bills are the ones who are going to have a high rate of distress about how they're going to pay their rent and mortgage, monthly bills, standard of living, retirement, suffering from financial hardship directly as a result of, I would say, the perils of medical care. This is something that never should have happened or allowed to happen in developed countries. In fact, these unfortunate coping mechanisms do not come in isolation. Javier Valero showed that these conditions go hand in hand. For example, if you look at this, among individuals who are unable to pay medical bills, 20% of them will have a combination of food insecurity, financial distress, and delayed medical care. Now, our cost-related non-adherence, as compared to only 2%. Overall, only about 19%, if you don't have medical bills, will have any of those coping mechanisms, where about 3/4 of these individuals who are unable to pay medical bills will have that. And by the way, those are millions of families with established cardiovascular disease in this nation. Furthermore, as shown by Ahmad, our cardiology fellow, higher out-of-pocket cost with while coupled, clearly I can understand that it may lead to emotional distress, financial subjective distress with these obligations and death and erosion of wealth, but also interfere with the patient's ability to cope effectively with cardiovascular disease adversity, especially affecting the quality of life, both physical and mental, their self-perception of health, non-specific psychological distress, and high risk for depression, all of which has now been well established in literature that's associated with poor outcomes and loss in quality of life, years gains. Now, another unintended consequences is foregone much needed medical care. Now, as eloquently detailed in this paper by Alex Thomas, nearly 50% of patients in heart failure, which is almost 1 in 6 of your heart failure patients, are going to forego much needed medical care. 50% of those are related to excess out-of-pocket cost. And clearly, as shown in this manuscript, that these are the patients who are more likely to end up using ED resources and eventually have a much higher total healthcare cost. So, just until a few years ago, while people didn't accept that financial toxicity is a real cardiovascular disease clinical issue and mainly prominent affecting only the cancer patient, now we know, thanks to Javier, that financial toxicity is not exclusively limited to the deleterious effect of costs related to cancer treatment. In this paper, Javier clearly debunks this popular belief and for the first time shows that, unfortunately, the burden and any of its consequences is definitely, if not higher, similar for patients and families who suffer from cardiovascular disease versus cancer. And just with the sheer more proportion of individuals suffering from cardiovascular disease, I truly believe that we need now the same vigor, passion, dedicated efforts to eliminate these challenges in cardiovascular disease, while there are thousands of papers and efforts and committees and organizations working together to mitigate that for patients suffering from cancer. Within cardiology, our insights is just limited to these handful of efforts. So why are we doing this? And what truly inspires us is we are trying to ring up the wake up call bells. And as Harlan clearly pointed out, we are doing this research to put the numbers to the issue so it cannot be ignored. You will see many folks saying that this is not a problem. We have done well enough. Things have gotten better, but we have to show them that no, we are not, and we still need to do more. And I'm pretty confident that these type of information would influence the policy debates about healthcare, and especially it will start happening when our governing organizations such as ACC will take notice. That's definitely one of the next steps. So putting together what we have learned so far, last year, Rohan and Javier published an amazing white paper that summarized our understanding of financial toxicity, socioeconomic, their socio-cultural drivers, especially related to CVD patients and their family. And I sincerely recommend this as a must read for anyone interested in this space, and more importantly, for our early career physicians in training. So as they're trained to see the patients and working towards overcoming the disease and maintaining health, the issue of financial toxicity definitely comes into the equation in our conversations. So clearly now we know that there are many more people, more patients, more families touched by financial toxicity than we thought. It's clearly an under-recognized, highly prevalent condition affecting millions of their families, eventually leading to loss of income, death, bankruptcy, tremendous amount of coping behavioral distress. And unlike clinical toxicity, the financial toxicity is more of a further potentially devastating consequence of CVD, where these patients are often led to manage at their own with tremendous downstream unintended consequences. So moving along, while we are now well aware about the potential intermediate impact, I think the effect of potential key outcomes have not yet been evaluated. For example, now we're considering two sets of outcomes. Number one, healthcare and clinical outcomes. For this, working with Rohan, we are aiming to systematically assess the following strategy, seeking out to merge the medical expenditure panels with full year public data sets to the NHIS personal level healthcare data that contains, so we can look prospectively in the next year of individuals who had suggested that they suffer from financial hardship, whether it will also downstream result in meaningful outcomes such as barriers to healthcare, rates of hospitalization, ER visits, and healthcare costs. And second, after more than 6 months of work, we have been able to merge and create linkage to more than 20 years of data in NHIS with the National Death Index. And this can help inform us on the most critical outcome, mortality, and the type of outcomes. Second, for financial outcomes, because not increasingly, there is a concern of increasing medical bill causing debt, bankruptcy, and adverse outcomes. But if also we do not have a clear understanding of financial toxicity is bidirectionally associated with CVDs, and how does CVD causes financial toxicity. For this, we are curating the Health Retirement Survey, longitudinal survey of a representative sample of Americans aged 50 years above. It's a prospective study and followed nearly 20,000 individuals every 2 years. And for this, we may have an ability to assess if a newly diagnosed of CVD results in significantly poor financial outcomes, such as future financial distress, loss of income, depletion of wealth, and potential increase in risk of death. So again, trying to have a more wholesome approach and trying to get more insights of whether this is mere an association or whether this would also lead to more accumulative reduction in wealth, higher financial hardships, and even death. Now, I think it's also time that we move the discussion from just acknowledging the problem to identifying them in the real world. While, of course, I couldn't agree more with any assertion that the main solution will still lie in the upstream advocacy to guide policy changes so that there could be a limitation of out-of-pocket cost, resulting in less objective financial hardships and subjective hardship. And it will be important to have equitable healthcare, possible growth of Medicaid, single-payer solution, and other national level levers for health financing, just pricing, regulations, and many other, which we will continue to, I think, so in the next few years, debate in both our policy and political circles. But till that happens, I think there are many opportunities within our own grasp. For this, we need to be thoughtful of potential, I would say, multifaceted interventions at the ground level and approaches that you and we can all develop, implement, and that test for mitigation, not only the burden, but also the possibly adverse outcomes. So as we are thinking this strategic direction, the first step is looking at it from the physician perspective. I think we are the major stakeholder in the majority of the decisions for medical decisions that relate to downstream cost. And while you and I have no issues and there is no limit in our conversation with patients, including their sexual life, drug abuse, mental health, somehow discussion on cost remains a taboo for many of us. Secondly, I see a total lack of, I would say, material or guidance from professional societies such as ACC, AHA on these challenges. And as the clinical practice guidelines do not incorporate any of the cost consideration in the clinical care framework and even in the patient-centered decision-making. As a result, we truly need to find out what is a sustainable engagement, and there is no way forward unless we have a better understanding from the physician's perspectives, the gaps and barriers. So for this, right now we are doing a diligent review of literature, mostly informed by what work has happened in cancer, identified nearly 70 main papers on cost discussions and patient physicians related to 4 themes: knowledge about cost issues and financial situations of patients. What are our cardiologists' attitudes about cost consciousness? Do we really believe in it? What do we do to address these financial hardship, if any? And what are the barriers to having these cost discussions? Because unless we have these insights, truly us as the main driver of these financial hardship, and I would say a segue of this conversation engaging with the patients, nothing will move on. Now, second, I would say similar to the physician perceptions, we have no idea about patients' perception of cost discussion. Would they welcome this as a relief or perceive this as a barrier of high care cost? Some suggestions are that the discussion about cost, and I've seen that even in my personal experiences, can be embarrassing for patients who could feel subject to social bias or stigma. And then again, in journal, the goal is again to engage patients and generate pilot descriptive data on how these patients view the goals and cost discussions for CVD management. This can allow for a more systematic approach to incorporate these cost care assessments, consideration about financial toxicity in our day-to-day workflow aids. And if we can implement a clinical practice questionnaire or intake forms, maybe the first practical step. Of course, once we get over the first barrier, a more detailed evaluation can be targeted to screen just with these questions of subjective financial hardship from healthcare, but we have no idea what our patients think about it. Third, the goal is would be to eventually develop and validate a patient-reported outcome tool to assess CVD-related financial toxicity in the real world, which will, of course, have to go through the rigor, all the hard work we are thinking about patients with newly established CVD and heart failures, combining work from the personal financial literature with health psychology, medical literature, prompt developments, making sure it has a reliable content and face validity, internal consistency, and then eventually that can allow for rapid implementation and testing. Fourth, I think that despite having now an improved understanding of the problems of financial toxicity that happens from these conditions, if you look at the guidance from the cancer literature, clearly there is an indication that lack of financial guidance resources and access to assistance program can be an issue. And actually can be the solution if we are appropriately identified and I would say adopt that. So here I again see another opportunity to develop a multifaceted approach to target lack of awareness and how to navigate the cost of care via financial resources. For this, we plan to engage patients with CVD and moderate amount of financial toxicity. We're working on developing a financial literacy course targeted to the patients. We also are working on creating local financial navigators, something that these resources exist in our own health systems for oncology patients, and we don't have to reinvent everything, but mostly scaling and leveraging those existing resources. And finally, completing the circle, following this, getting good insights on whether the development and implementation of these potential navigation resources, education material, and our engagement can eliminate or overcome some of the financial burden. So we plan to test this in a pilot study. Not only the implementation, we want to understand the processes, the barriers, the impact of these programs that will have for the patients with resources to proactively, so that these can manage the cost of their CVD, can become informed consumers. And to this end, we can adopt and refine a comprehensive financial literacy and navigation program that once they are designed and adopted into a more of a large scale RCT. So in brief, what we are trying to do is really develop a strategic, pragmatic roadmap that has its roots in truly the work that got started at Yale. And 3 years ago that the journey we started, and now we have identified together the domains, scope, vulnerable groups, the coping mechanisms, the potential intermediate outcomes. I think there is tremendous opportunities to fill the next gaps, especially with this Houston Methodist Yale collaboration, where we can define the outcomes and associations. We can understand our stakeholders' perceptions, beliefs, develop a prompt that can be adopted in real world and modified to different needs of various CVD conditions. Work with our partners in community, patients to develop an education program and potential financial navigation program, test in a pilot study, and whether we can overcome these issues. I really think for these complete cycle of initiatives, I'm hoping that we can energize many early career at Yale Cardiology to join hand in this effort. So moving on, it's very clear now that financial toxicity is a much bigger problem than many of us realize. Unfortunately, most of our patients suffer in silence. They take on medical debt, even taking time off of care for their family members. And they do all in the silence because there is no one asking them. And also they think this is the right thing to do. I hope together we can make this a priority in illuminating it, identifying those who are vulnerable, and not only stopping there, but taking the next step in seeking solutions and working with partners. So not only we help our patient break their silence by talking to them, but also help them out of their misery. And I think with this financial toxicity overall in CVD management, we are at a pivotal juncture in the history. Yes, we have come a long way over the last 20 years in addressing issues such as underinsurance. It has been a difficult journey. I don't think so it's over yet. As you can still see, we have a long way to go for mitigating financial hardship, and especially in our own community for the patients that we are able to see. And truly, I think so the current traditional healthcare delivery system as it's constructed right now in the US, it's not really set up to have any of the impacts that are needed to change this trajectory. Although we are doing great on someone's health, but at the same time, we are not protecting them from financial toxicity. And while these recent, I would say the COVID crisis, thankfully has shored up all of our motivations in addressing inequities in healthcare, even including related to cost and social risk. I think that we have a pivotal opportunity that one size will not fit all. We must refrain from using the same old strategies because they will result in the same old results. And if we aspire that the benefits of these advancements, these insights, we can share equitably across race and social boundaries, I think it's time for all of us, especially physicians, health system, our community partners, our local and national policymakers, our patients, our research community to come together and do our utmost to mitigate the pervasiveness of financial hardship and its consequences. And I'm very hopeful and optimistic that by thinking outside the box, and especially with multi-pronged strategies, addressing these social and economic factors will make a big leap towards our mission of, at least for me, becoming prevention of financial toxicity and providing financial protection, so that this can not only cascade through yours and mine health ecosystem and beyond. So I truly hope in the next 5 years that the cost would not be the biggest discussion that we are having, and we can all come together for a solution. And again, thank you so much for the attention. I look forward to your comments and feedback.
Khurram, thank you so very much for that excellent talk. The chat is open and also hand raise function. I'll start with this question from Yiwa Liu. And they're asking, what would be the major factor to drive up medical care cost and insurance premium? I think this is important. Is it medical staff salary? Is it medical devices, prescriptions? If all the three, what is the percentage contribution among the three?
So, and then again, there are many types of cost. One is the overall cost. Of course, when we are specifically talking about what relates to our patient is how much they're paying out of pocket cost. So 1/3 of the cost is definitely the premiums. Of course, in that regard, definitely having national programs like Medicaid and Medicare would help, but definitely there are deductibles. Out-of-pocket costs are immense, especially for Medicare patients for prescriptions. As you can see that 1/3 of the entire cost is out of pocket, is based on medical prescriptions, clearly related in Medicare program where you have to pay almost 20% out of the pocket unless you reach the maximum deductibles. Now, when you talk about the overall healthcare costs, there are many other factors such as merging of large healthcare systems coming together really to become monopolies in system. For example, partners in just the Northeast market is able to generate 75% of much higher rates for the same amount of procedures and same amount of quality and outcomes as their peers. And of course, all of this that gets transferred. So multifaceted things are affecting it. There's no one really, I would say, domain that's affecting more. But for the patient out of pocket, premium is 1/3. 1/3 is medical cost from prescription, and non-premium about 1/3, half of that is medical prescriptions.
Okay. Dr. Zarek?
Yes, thank you. Wonderful talk, and it's great to see you again, and you continue to impress me since your fellowship days. A question and a comment. The question, as you look at financial toxicity and outcomes, you're looking at mortality and a number of other measures. I hope you're also looking at readmission rates, because I would think that readmission rates can be part of a vicious cycle that occur for patients not taking medicine, et cetera, being readmitted to the hospital. Their debt then goes up and up with each readmission. The comment is, I don't think this is something that's going to be fixed quickly. There are so many forces moving against change. The pharmaceutical industry, the hospital industry, the instrumentation industry, et cetera. I think there's a need for a new cohort of people to work with patients, and that would be financial ombudsmen. I know I've tried to deal with this when I was still seeing patients over the years, and it was very difficult to do as a physician. But I think there needs to be a cohort of people who are not social workers and not physicians, who are specifically trained to deal with these financial inequities. But thank you for a superb talk.
Thank you,
Dr. Zarek. Oh, sorry, go ahead, Khurram.
Yeah, thanks again. You're absolutely right. Your, I would say, observation on readmission is very valid. So unfortunately, in the national data sets, we do not find that. However, we are creating a financial toxicity questionnaire out, and we are planning in the next 6 months to administer for our newly diagnosed heart failure and CVD patients to really look at the longitudinal experiences. Now, regarding the second point, you're absolutely right. One of the key things is that as the medical society, we need to realize that this is an issue. For that, we need to start screening. There are actually, what I have found, that actually there are resources within our own health system and community where we can refer. It's not a social worker, but people who are financial navigators. And actually, I found it extremely useful. But the question is, where do we start? Which patients to select? Can we use a single screening questionnaire? Should it be part of our initial intake, that every of these patients that we can eventually refer to? So till, of course, it's going to take a while for the policy changes to happen that will shift these out-of-pocket costs and we become more like other developed countries. But till then, I think that just having the awareness that these resources exist and testing and implementing them to really mitigate those effects will be very helpful.
Excellent. Dr. Sufer?
Hi, Khurram. That was excellent. As you're outlining this problem, it's if we all agree that it's systemic, then there has to be different scales in the problem and approach. And the economic circumstances are such that we have a reductive approach in medicine, because the goal is to reinforce some of the economic resources that we get and the hospital gets. So we are victims too as caregivers in the system. And once these behaviors are consolidated in order to get the economic returns, I wonder if you're looking at this I know you are, but I just wanted you could share that you say that the system reinforces certain things I've just said, but also reinforces these coping mechanisms for the patients. And you mentioned a lot of mental health states that current literature says that if we wanted to have the lowest mortality, everybody had access to care. This is a Rand Corporation, 3 other papers saying that if everybody got the right medication, everybody adhered to it, that the variability of reducing premature deaths and morbidity and mortality in medicine in general, not just cardiovascular, it would only be reduced by 10%. And the variability for improvement is in the psychosocial domain, which is completely ignored. And so we have a system that actually is promoting a part of the qualitative aspects of a patient experience, which promote more disease, which actually reinforces the reductive approach. And I wonder how do you look at that, and how do you incorporate that into your model?
Well, very challenging issues out here, as your work and others have shown how psychological distress now, it could be family related, it could be relationship, but of course, socioeconomic really goes up much higher. Definitely what we have scratched the surface right now, where we just seen that patients who have more difficulty paying bills are the ones who are going to have the highest challenge. Now, the question is, would reimbursing or helping them, would that lead to those changes? As you can see, is Bob, we are literally at the first step, and there is so much that needs to be done, but it cannot happen with us alone. And we need more of, I would say, even thoughtful leaders and translational scientists like you and others joining head and saying, to understand even the biological processes, and more importantly, the interventions that could lead to improvement and outcomes. So I would love to discuss more with you offline on this, but thank you for your comment.
Thank you. We'll take another question. We have maybe room for just a couple quick ones. Dr. Lampert.
Thank you. Khurram, that was a fabulous talk. So my question / comment, you have talked about a lot of approaches for trying to help the patients navigate the world we live in, and how we as physicians, we can choose wisely, this kind of thing. But the problem really is that we need to change the world we live in, not just figure out how to adapt to it. It really seems like we have an unregulated insurance industry that pits the well-being of the shareholders against the well-being of the physician, of the patient. We have, unregulated pricing, and it seems like these are the bigger issues. How can we absolutely, it's going to take a long time to change that, and we have to teach our patients how to live within it. But how can we change this to make a more reasonable world that we all live in?
So as you know, I earlier pointed out, the real solution is exactly what you says, is having wholesome policy changes to ensure less out-of-pocket cost, at least capping up, having some systems that we see in other health developed countries. Now, for that, as Harlan pointed out, you really have to start illuminating, because one of the key things is we just don't know what's the scope, what's the burden, what's the outcomes. And hopefully a lot of this work can lead to those policy and political debates. We need to be advocate. I think for the next step, Dr. Lampert, is truly ACC to get involved in the advocacy, because you and I and Rohan and Harlan alone, we are few voices. We need someone from ACC to recognize this and take it to the next step, to the legislations, to our state departments, to Medicaid. For example, the whole burden of out-of-pocket cost in Medicare patients, in spite of the fact that almost it's been paid, many of these patients cannot afford those costs. I think so. Those are the steps that will need to happen. It will take a long time. I will be surprised if we get there in the next 10 years. Till then, I feel very helpless that we cannot do more. And I think so that is really the motivation factors, that at least I can start having those conversations. I can start choosing wisely. I can see what my patients, whether I can help them with our localized resources. And can we make an impact in the interim? But the long-term solution is really what you pointed out.
Thank you so much, Khurram. I know folks have to go away at the top of the hour, but maybe we can take a couple more comments. Dr. Gerber.
Great. Yeah, thank you. That was great. And I thank you so much for making everybody uncomfortable in their own economic skins. If you're not uncomfortable, you're not learning. This is a systemic issue. So one of the things that's always been interesting to me, what are the unintended consequences of governmental interference, such as the development of provider-based practices, site of service differentials, the ability and the change in the business model that catalyzes both vertical and horizontal integration that, as you correctly point out, reduces competition and drives up costs in every local market. So that's number one. And probably every group you talk to has a bunch of docs in it who previously were in private practice and they had to join or wanted to join other systems because of the changing business model in medicine. And then the other aspect I wonder if you could comment on is the impact of defunding the ACA subsidies, because this group you're talking about is going to be largely in that area because they're the ones who are taking the high deductible policies. They're squeaking by on substandard or sub reimbursed jobs, and they're looking to get some coverage, and they take a $7,500 deductible, and they don't have the money to cover the deductible when it does hit. And the subsidies were originally meant to cover those folks. So subsidies kick in and make that more available. But I was wondering if you could make some comments about governmental policy and ACA subsidy.
So big challenges you pointed out, Dr. Gerber. But again, my experience, one is that definitely we have to continuously move towards a clinical integrated network in the sense of adding more value, efficiency. There is tremendous amount of ways that can be prevented. You can look at systems like Montefiore, which is serving largely a low income Medicaid, Medicare, but still making 7% margins as compared to larger systems who are not integrated, not even to do that. Definitely a lot of waste is happening. So even with low reimbursements, you can make a reasonable profit, which should be the part and parcel of any business, be it include healthcare, but doing it in a way that it's not affecting or imposing financial toxicity to the patient. And differential insurance rates negotiations has to hand. I think so. The model towards capitation is going to sometimes move into that direction. Of course, you can have supplement, complement insurances. Many, of course, there's no one right answer, and everything we do is going to have some unintended consequences. The issue is from a policy perspective, which one has the impact on the most individuals. That's number one. Subsidies, I think with the Obamacare, unfortunately, as far as if you're not doing group insurances, the deductibles are becoming a huge challenge, although it may provide some support from catastrophic healthcare expenditures, but the studies have definitely shown high deductibles significantly associated with financial toxicity. I think so. There'll be a need for more of a governmental support in individuals rather than going through those subsidies. But very huge issues. Of course, we need advocacy and working with ACC and our political, I would say, representations to make those changes happen.
Khurram, I just want to thank you again. I'm noting, Matt, your comment here saying really we should be focusing not on the chronic disease management, but on prevention and refocusing efforts on that. And I think that we all, Khurram certainly agrees. But I want to take the time to really thank you for an excellent, very provocative talk, and kind of really looking forward to the next steps of this work in figuring out how we actually implement this and help to protect our patients from some of the worst outcomes from financial toxicity. So I thank you very much, and please attend the symposium on Saturday morning so that we have more discussions on this and other topics. Thanks everyone, and see you again next week.
Thank you so much. This was fantastic. And of course, again, an open invitation to a lot of our young investigators to join these efforts with me and Rohan and Harlan. I think so there's tremendous amount of opportunities, not only for scholarship, but to make an impact. But thank you so much.
Thank you.
Okay.